Welcome to This Explainer. Today, we're diving straight into one of the most culturally loaded, heavily debated, and honestly just totally misunderstood topics in human behavior. I mean, we hear terms like hypersexuality and sex addiction thrown around constantly, right? Pop culture, the media, if a celebrity has a public scandal, these labels are basically handed out as a get-out-of-jail-free card. But what's the actual science here? Today, we're unpacking the reality behind the labels, cutting through all that gossip, and figuring out how modern medicine truly views this incredibly complex issue.
So, let's kick things off with the ultimate question. Where exactly does healthy desire end and an actual disease begin? Because, human sexuality exists on this incredibly massive spectrum. Figuring out when a behavior actually crosses the line from a naturally high libido into a clinical pathology, well, that requires us to look way past our cultural biases. We really have to dig into the raw neurology and psychology at play, setting aside decades of stigma to find that exact line between a totally healthy appetite and a genuinely destructive compulsion.
Here's our roadmap for today. We're going to cover desire versus disease, the myth of nymphomania, redefining the disorder, inside the hypersexual brain, and finally, treatment and reclaiming control.
Part 1. Desire versus disease, drawing the line. Let's jump right in and separate the cultural judgment of quote-unquote too much sex from the medical reality of a disorder.
Okay, it is absolutely crucial that we strictly separate a naturally high sex drive from what clinicians now call Compulsive Sexual Behavior Disorder, or CSBD. This distinction is a huge deal. Having a lot of consensual, enjoyable sex is not a mental illness. A high libido is enjoyable, you're in control of it, and it doesn't tear your life apart. CSBD, on the flip side, is marked by immense, overwhelming distress. It's behavior that is completely uncontrollable and causes severe harm. We're talking wrecked relationships, health issues, or even entirely draining your bank account.
The real hallmark here is a total loss of brakes. The disorder isn't defined by how often you're being intimate. It's defined by the total loss of control and the fallout that comes with it. Someone might desperately want to stop, but they literally just can't. They keep going even when it actively threatens their job or their marriage. And there's this devastating paradox at the core of it. As the behavior escalates in search of a high, it actually brings less and less satisfaction. The pleasure just fades away, and it's replaced by a brutal cycle of guilt, anxiety, and shame.
Part 2. The myth of nymphomania, a dark history. To really grasp where we are today, we absolutely have to look back at the deeply misunderstood history of female sexuality. So, before the 18th century, excessive sexual desire in women was actually called furor uterinus, or uterine fury, literally. This was based on an ancient Greek concept of a wandering womb causing madness, which ties back to humoral imbalance, the idea that your bodily fluids controlled your sanity. Fast forward to the 18th and 19th centuries, and this morphs into nymphomania. Physicians viewed female desire as a somatic disease. Basically, they treated it as a physical bodily defect, not a complex psychological state. And honestly, it is shocking that it wasn't until 2019 that the World Health Organization officially classified compulsive sexual behavior disorder in a totally gender-neutral, evidence-based way.
It is absolutely wild to see how these interventions have evolved. We went from humoral adjustments and herbal remedies to invasive physical punishments. Historically, if someone had what society deemed excessive desire, they were treated based entirely on cultural norms and fear. Today, thankfully, we treat it as an impulse control dysfunction, using specialized therapy and carefully administered medication. It is a completely different world.
We really have to acknowledge just how dark this period was in the 19th century. Any deviation at all from the passionless Victorian ideal for women was met with incredibly invasive, oppressive treatments just to physically suppress that desire. Doctors actually believed they had to cool the female body down with freezing cold baths or super restrictive diets. Fun fact, or maybe not so fun, things like graham crackers and cornflakes were actually invented during this time specifically to be as bland as humanly possible. They honestly believed flavorless food would stop sexual urges. But in extreme cases, the medicalization of a moral standard went way further, leading to irreversible surgical interventions like clitoridectomies.
Part 3. Redefining the disorder, science takes the lead. Moving into the 20th and 21st centuries, the medical community finally started to shift away from moral policing.
And this brings us to the modern definition, which completely strips away the weaponized, gendered baggage of old terms like nymphomania for women or satyriasis for men. Instead, we get a neutral, clinical lens. CSBD, as defined in the International Classification of Diseases, focuses entirely on the persistent failure to control these intense impulses. You can only imagine the immense relief this new, neutral definition brought to patients who had been stigmatized for so long. It's no longer about judging the desire itself, it's strictly about recognizing the extreme distress and the impairment it causes.
Now, there is a massive debate hidden in these medical classifications. Pop culture absolutely loves using the term sex addiction, right? But major health organizations explicitly avoid it. Why? Well, the scientific evidence just doesn't equate it to the physical, chemical dependence we see with substances like alcohol or opioids. Calling it an impulse control disorder is a much more precise way to describe the behavioral failure to stop. A person isn't going through a life-threatening chemical withdrawal when they stop the behavior. They are battling a deeply entrenched psychological impulse.
Part 4. Inside the hypersexual brain, neuroscience, and trauma. Let's pop the hood and dive deeper into the biology here.
When you strip away the behavioral symptoms, you find some incredibly complex neurology. Science actually shows us how the brain's control mechanisms can literally be short-circuited. For example, we see hypersexuality show up in patients with dementia or Alzheimer's because of organic disinhibition. The physical brakes in their brain are quite literally wearing away. We also see it after severe brain injuries, like Kluver-Bucy syndrome, where there's severe temporal lobe damage. And maybe most fascinatingly, it can be a direct side effect of certain medications. Dopaminergic drugs, which are often given to Parkinson's patients to help them move, can accidentally flood the brain's reward pathways and totally override normal behavioral control.
But hey, biology is only half the story. This quote perfectly bridges the biology with the psychology. It frames compulsive behavior as basically an autopilot delivery system for neurochemical relief when early emotional needs aren't met. People who experience severe neglect or trauma often learn to associate sexual behavior with a reliable way to self-soothe. The brain forcefully wires itself to generate relief internally because it can't find reliable emotional regulation from the unpredictable outside world. That is the profound impact of an attachment wound.
And the numbers absolutely back this up. To put this into perspective, over half of these cases, around 55%, are rooted in severe childhood trauma or abuse. In these situations, the brain learned really early on to associate sex with a necessary, desperate escape from emotional pain. So what starts out as a tragically necessary coping mechanism eventually spirals way out of control into a full-blown compulsion in adulthood.
Part 5. Treatment and reclaiming control. Finding balance. So knowing all of this, the rough history, the neurobiology, the trauma, how do modern clinicians actually treat CSBD and help people get their lives back?
Well, thankfully, treatment today is highly structured, multifaceted, and deeply empathetic. Step 1 usually involves cognitive behavioral therapy, or CBT. This actively rewires the brain's response to triggers so a person doesn't just automatically act out the second they feel stressed or abandoned. Step 2 can bring in specific medications. Drugs like naltrexone can actually lessen the chemical dopamine rewards the brain receives when acting on the compulsion, which makes the destructive behavior way less physically satisfying. And finally, Step 3 involves structured support groups. This is absolutely crucial to shatter the isolation and the shame that fuel this disorder so heavily.
If you take away only one thing from this explainer today, it needs to be this. The goal of recovery is never, ever to erase desire. The goal is to empower the individual to enjoy it safely. Unlike treating a chemical drug addiction, where the goal is complete abstinence, treatment for CSBD is all about integrating healthy, controlled sexual behavior back into a person's life without those destructive compulsions. It is entirely about reclaiming balance, joy, and agency over your own body.
As we wrap up, I want to leave you pondering this. When we look back at how we historically treated the so-called wandering womb, compared to how we compassionately map dopamine pathways today, you really have to wonder about the incredibly complex evolution of human desire. How much of what we label as a disease right now might just be a misunderstanding of human nature? Thank you so much for joining me on this explainer, and remember, always keep questioning the world around you.